can help you.
Just project anything. I can talk about it with my eyes closed. It's all good. Yeah, I said I can start with the second.
No problem about that.
I'm happy to do either. Any slide would be helpful.
Finding the lecture.
No, I found it, but it's just weird. There's something
You could start with the other one. You could start with the second one.
Start with the second one.
Yeah, it's okay to switch the order. It's the same.
Yes, no problem about it.
Just let me talk about something so that these people don't go. Sure.
During that time,
Maybe you can work on.
to upload this first one.
There's something wrong with the first picture. It's not about that
Well,
laptop or something.
that's why I came 2 hours ago. Anyway, can I just show
Can't
any
start.
slide? Good afternoon. I'd like to thank the organizers for the kind invitation, Professor Hasham, our moderators as well. Also, sorry for the technical delay, even though brought these slides in. I'm going to actually start with my second talk first, and then get to the first talk. I apologize for my voice as well. It's a privilege to be back here. I was at BGICC, the first one, and many times over the years, and now the 15th annual meeting, so really wonderful to be here. Ductal carcinoma in situ, this is something we all know about. Everyone sees these types of patients. We operate on them all the time. Yet, those of us that have been working on de-escalating therapy has been something that is somewhat controversial, both in the United States and around the world. It was in 2015 when I was quoted in Time magazine as one of the few surgeons at that time that was looking at de-escalating therapy for DCIS, including not operating on these patients. So I want to go over how we built the current randomized trials that are underway, the COMET, LORIS, LORD. What is the data that supports maybe there is a subset of patients with ductal carcinoma in situ that does not need operation? Good, I'm good now. Surgery and survival benefits. So Yasuaki Sagara, who is a postdoctoral fellow of mine back in Japan, we published this in JAMA and presented this as an oral presentation at ASCO in 2015. We were trying to identify a group of patients with ductal carcinoma in situ that potentially we did not need to operate on and still not be a detriment in overall survival and outcome. We know that in the United States, there's about, actually this number is a little low, it's probably closer to 65,000 patients with ductal carcinoma in situ each year. That's over 250,000 for invasive breast cancer. It's about a quarter of our patients. But we also know that DCIS, just like an invasive breast cancer, is not a uniform disease. There are those that are low or intermediate grade. Not all go on to become invasive breast cancer. And we certainly know that higher grade disease puts a patient at risk of local regional recurrence. And the standard of care has traditionally been either lumpectomy with radiation, mastectomy, plus or minus anti-estrogen therapy. So what we wanted to do was to see what was the magnitude of benefit, if any, of surgery for DCIS, and to find out a large enough cohort of patients that did not undergo surgery, we used SEER, which is one of our two major population registries in the United States. There's SEER, and then there's the NCDB, which we use in oncology quite a bit. And we were able to code patients because, again, to identify enough patients to be able to make any conclusions that did not undergo surgery for ductal carcinoma in situ, if you look at single institutions, that number is relatively low. There's obviously lots of differences and challenges when you use a data set like this, and so we use propensity score weighting to match some of the differences between these variables that we end up seeing. So we looked at women over 20, about 100,000 patients. We then wanted to make sure that we had the pathologic and nuclear grade, and we had a final analytical cohort of 57,000 patients. So we excluded patients with DCIS, with microinvasion and others. Interestingly, we are able through SEER to also be able to identify why some of these patients did not undergo surgery. So 547, or about 47%, the physician did not recommend that the patient undergo surgery. And there was also those that were recommended to undergo surgery, but the patient didn't. So we identified nearly 1,200 women in the United States who had DCIS that did not undergo surgery. And then when you compare that to those that had surgery, certainly there are going to be some differences between those groups. And obviously the first is that there's so many more patients that underwent surgery, 56,000 patients. But there was differences in age. So patients that were older or more mature in age were less likely to undergo surgery. And there was a difference in terms of race and African American. In terms of the tumor size and grade, those that did not undergo surgery tended to be lower grade disease compared to those that underwent surgery, which was higher grade disease. And then if you did undergo surgery, you were much more likely to undergo radiotherapy. So of that 1,169 patients, 14% underwent no surgery but had radiation done. So this is 72 months follow-up. It's pretty robust. And I think the most important thing, one of the many important points here is that, first of all, the risk of dying of breast cancer is remarkably low. It's 1%. But if you're going to die, it's much more likely going to be of something else and not related to breast cancer. And then overall, when you look at all of our patients, the survival between breast conservation and the surgery versus the no surgery group, you do see a numeric difference, but we're going to go over how we adjusted for this. So for low-grade disease, there actually was no difference in breast cancer-specific survival, although there was a difference, though, for those with high-grade disease, and you can see a moderate difference with those with intermediate-grade disease. And when we looked at the effect of surgery based on nuclear grade, again, there was no difference in overall survival, or breast cancer specific survival for low grade disease, but yes, we did see it for intermediate and high grade. So this was the first study in the world done at the time that showed this with a significant number of patients that showed survival benefit on DCIS based on nuclear grade. We used propensity score to balance the clinical pathologic differences between these patients. We had to use a large data set to be able to do this, but of course, there's confounders whenever you do a retrospective study. Selection bias, surgical margins are not available in SEER. The use of endocrine therapy isn't available in SEER, but is in NCDB, and I'll get to that in a moment. So we said that the survival benefit for low-grade disease was smaller than for intermediate or high-grade disease. And again, these are a lot of the bases that are being used for the current trials. So how about radiotherapy? We certainly know from the EBCT-CG group that radiotherapy certainly reduces the risk of subsequent events for after breast conservation for both invasive breast cancer, but also for DCIS as well. We also know that breast cancer mortality between breast conservation and the radiation therapy group, non-radiation therapy group for invasive breast cancer, there is a difference. But for DCIS, there's never been a large enough study or cohort of patients to show whether there would be a difference in survival with DCIS. And this is, again, how we're building our question of, can we identify a group of patients with ductal carcinoma in situ who does not need surgery? So the results from those meta-analyses that have shown that radiotherapy following breast conservation for DCIS, that half of the recurrences are invasive, the other half are non-invasive, that our radiation therapy reduced the recurrence by 50%, and that was really irrespective of tumor type or patient characteristics, but that in DCIS, radiotherapy did not improve survival. So we published in JCO, this has been now 7 years ago. Again, Yasuaki and I decided to look at whether we can use the patient prognostic score to identify a category or a group of patients that would or would not benefit from radiotherapy in terms of improving their survival. So we wanted to hypothesize that there may actually be a survival benefit for a subset of patients with DCIS. Back to SEER again, we used the SEER 17 registry, started with 76,000 patients. You can see our exclusion criteria. We came down to a final analytical cohort of 32,000 patients. And then in the two groups, you're going to see that there was in the no radiotherapy group versus the radiation therapy group, we had about 10,000 patients in the no radiation therapy group and 18,000 in the radiation therapy group. And yes, you do see a numeric difference in those that were alive or dead. But again, the important thing is that your overall breast cancer specific mortality for DCIS is low. It was 1.3 versus 0.8%. And if you're going to die, it's very much likely more from something else and not related to DCIS or breast cancer. So the cumulative risk of breast cancer specific mortality at 10 years, this was at 10 years, was for the radiation therapy group was 1.8 versus 2.1%. So you can see that there was a statistical difference. But then we wanted to look at what were the characteristics. Younger age versus lower age, the amount of DCIS in the breast, and then the grade of DCIS. So the patient prognostic score, which was by Hafty's group and others, suggested that if you were older patient, and in older they said over 60, and I know that's, you know, the definition of elderly has changed, smaller amount of DCIS, less than 16 millimeters, a low grade, you would get as low or a 0 score, but a younger patient, larger area of DCIS, higher grade would get a higher score. Interestingly, in those with the lower numbers, you did not see a difference in terms of overall, for breast cancer specific survival, when you applied radiation versus not. But those that had more aggressive features of their DCIS, although the numbers were smaller, there was a difference in survival. So we concluded that with the patient prognostic score, these are simple things that are available. You know the size of your DCIS, you know the age of the patients, you know the grade of the DCIS, that maybe there is a cohort of patients that would benefit from radiotherapy in terms of their overall outcome or survival. There was an editorial that was associated with that. So then the final thing was that we didn't have a lot of information on use of anti-estrogen therapy in margins. So the National Cancer Database from the American College of Surgeons, or the Commission on Cancer, is another data source that is available that captures about 93% of our breast cancer patients in the United States. So what we wanted to do was, I first talked about the effects of surgery on survival. Then I talked about the effects of radiotherapy for DCIS. Now it's endocrine therapy. So using NCDB, because we have information on the use of endocrine therapy, we started, it's a larger cohort because it captures more patients, 183,000. Looking at the exclusion criteria, we came down to a final analytical cohort of 66,000. Median age was 60, and the average age of breast cancer invasive in the United States is 62%, and you can see that these tend to be more healthy patients, and the number of cases of DCIS over our study period increased. Most had smaller areas of DCIS. Most, 75%, were estrogen positive. you can see that about 60% of our patients had grade 1 or grade 2 DCIS. And then in NCDB, we do have margin information. So 95 or 96% were able to get final clear margins. Now the challenge is, what's the definition of a clear margin? And we can certainly talk about that a little bit later. Over time in the United States, what we did end up seeing is that the use of radiation therapy and endocrine therapy combination increased, that the use of radiotherapy alone decreased, and that's on your left side. On your right side, interestingly, for those that had estrogen receptor negative DCIS, there was still a small cohort that received endocrine therapy only, which didn't make much sense to me, or radiotherapy and endocrine therapy. And again, this was for estrogen negative DCIS. The use of adjuvant therapy between the 2013 and 2004, for when the study started and when the study stopped, you can see what happened to the use of radiotherapy, endocrine therapy, and combination therapy. Over time, that was one factor. Then we looked at the effect of age, and as the patient became more elderly, or older in age, the receipt from radiotherapy decreased, the rate of endocrine therapy or combination therapy decreased as well. Certainly those that had larger areas of DCIS or higher grade were more likely to receive radiotherapy. The use of endocrine therapy was associated with grade, but not necessarily the size of DCIS. And then again, a combination of radiotherapy and endocrine therapy was with higher grade. Looking at margin status, positive margins were more likely, you can see the difference between positive margins and the decrease in the use of radiotherapy and endocrine therapy as well. And then if the patient had a lot of comorbidities, less likely to receive radiotherapy. And then looking at the use of radiotherapy and estrogen therapy, certainly those that had were uninsured in the United States, and this was before the Affordable Care Act, or what many people call Obamacare, and the differences associated with that. So why did we do this study? Is that we were able to show that there is a cohort of patients that has increased in the United States that has use of endocrine therapy only in a low risk group. That was hormone receptor positive patients with ductal carcinoma in situ. So again, these are all used to build up rationale for how we go to the randomized trials. I'm going to quickly just go over the trials that have been underway or have recently concluded. The LORES trial randomizing low or intermediate DCIS to vacuum-assisted biopsy. And in the UK, that was randomized to surgery versus active monitoring, and their primary endpoint was ipsilateral invasive breast cancer recurrence. And this is their trial schema, which I'm not going to spend too much time on. It's actually pretty exciting to report that COMET, which was started by Shelley Wong and Ann Partridge, my former colleague at Dana-Farber, and Alistair Thompson in Houston, and Liz Frank, who's been the patient advocate lead and a colleague of mine from Dana-Farber, just finished accruing, yes, two days ago in the United States. So hopefully we'll be able to get some data on the randomized trials for de-escalating therapy for ductal carcinoma in situ. In the United States, we're a little bit more, I don't know if conservative is the right word, but we were not as comfortable with either excluding endocrine therapy completely, and then in terms of the amount of imaging that ends up being required. And again, patients with estrogen positive DCIS were very strongly encouraged to consider anti-estrogen therapy, and that wasn't really seen necessarily in our in the UK study. And then the imaging that's required was more intensive, meaning every 6 months for those that underwent non-traditional surgery. And the surgery for this trial was either lumpectomy alone, lumpectomy with radiation, or mastectomy. So the NCI definition for cancer you can end up seeing that in all, that in my opinion, DCIS is not cancer. In some cases over time it may become cancer. I do think we are over-treating DCIS, and I do think that results of trials done both in Europe, in the UK, US, and around the world will hopefully further refine and show what population of patients would be appropriate for de-escalating therapy for ductal carcinoma in situ. But before you get to the randomized trial, I wanted to show you the data that showed how we got to that. So with that, come and visit Boston or Connecticut. We get a little bit more snow than Cairo. That's my son digging me out of a recent snowstorm. So thank you so much for the privilege of the podium, and I'm happy to answer questions, and hopefully my second talk will be uploaded by then. Thank you so much.